My next paper is, I'm presenting the results of a randomised controlled trial I did, comparing strengthening and postural education in age-related hyperkyphosis. And this was actually the focus or the end point of my PhD. I did a lot of other studies, but this was the main point. So just by way of background again, as I've said, the thoracic spine becomes more kyphosed with age, and hyperkyphosis defined as 40 degrees. But one thing that you might be surprised by is that the prevalence of hyperkyphosis in males and females over the age of 65 is greater than 50%. And that's in people that have no evidence of osteoporosis. And this increase in curvature is important because it can result in pain, physical dysfunction, respiratory dysfunction, and also an increase in osteoporotic vertebral collapse, which is shown very nicely by Andrew Briggs, where if you're already kyphosed, then the forces on the anterior vertebra are such that if you then are unfortunate enough to develop osteoporosis, you're likely to get collapse of those vertebrae. So this increase in vertebral kyphosis, although of course the major element is bony, a lot of the shape can be explained by the soft tissues, and we've got figures in the literature between 42 and 78% of the curve being explained by the vertebrae, the rest being explained by the soft tissues. And we've talked about the discs and also, of course, muscle weakness and stiffness of ligaments, etc. And it's these tissues that are conservative measures for when we're treating people with hyperkyphosis or with kyphosis aim to address. We did a study a couple of years ago where we did a survey of Australian physiotherapists, and we asked them what it was that they used to treat kyphosis. And there are three big ones, by far the biggest: postural education, secondly strengthening, and thirdly stretching. And if you look at the papers that have been written trying to evaluate whether what we do for thoracic kyphosis is effective, this is the list we get. So we get about 9 papers there. Now, if you look on the right-hand column over here, you'll see that the amount of change that people have seen as a result of their conservative programs is pretty underwhelming. And if you take out the uncontrolled studies, it's more underwhelming. With the exception of this one down here, the Emery one at the bottom, my little thing, which showed a significant difference between the control and the exercise group in a Pilates study. But the difference between this one and the rest is that the mean age of their subjects was 30, not 60, which the others were. So although in the younger cohort, this sort of multimodal Pilates will have worked, I wonder whether it would have worked in the older groups. Now, the next most convincing study is this one by Greendale, which was a yoga study. It was a very good study. But there, if you just take their angle changes, the difference between the groups was not significant between control and exercise group. Now, so we're not really coming from a very impressive standpoint here, but we want to know, well, look, people are throwing everything at this. We're looking at posture education, strengthening, stretching, whatever else goes into that bag, because all these are multimodal. We wonder whether, if we put our energies into one particular modality, maybe it would be better. So we wanted to determine the relative efficacy of the 2 most frequently used therapeutic strategies for age-related thoracic hyperkyphosis. And we chose posture education because it was the biggest one. And then we chose to use strengthening. I could have used stretching, but we chose strengthening. And we chose to use progressive resisted strengthening because that's, the evidence suggests that's the most effective strengthening modality. So we had subjects over 40, again, no osteoporosis, no previous back or operations or pain. And we had a cohort of 69, 26 males and 43 females, mean age of 63. We randomised into 4 groups: control, strengthening, posture education, and both, and that's a 2x2 factorial design. And our gym group, that was a 12-week intervention, and we asked our gym group, this is a big ask, to go to the gym 3 times a week and to do 4 by 10 repetitions at 60% of their 1 repetition maximum, which has been reported to be the most effective way of increasing strength in untrained muscles. And they incremented this weekly. The posture education group went to the physiotherapist 3 times over this 12-week period, and that figure came from our survey. That's what was people nominated was a reasonable time. And They were assessed and prescribed a home program and given lots of advice, and they came back 2 further times for review. We made our measurements at baseline and 12 weeks, and again we used the biometrics flexible electric goniometer. It's a static and dynamic, so over 6 hours, and some measurements in the clinic. And I should point out that this device measured between about T3 and T11, so just the apical segment of the spine, and we used the dual electronic inclinometer to measure the whole spine, but that was static only. So, physical function tests included a 10-meter walk, timed up and go, times per sit to stand, and a stair test up and down 4 stairs 3 times without holding a handrail. And we measured strength with a dynamometer fixed to a wall, and we normalized that by body weight. I should say the test was done with the hands hanging down by the side, and we controlled for any pushing through the feet. And these are the results. Busy slide, I'm sorry, but I'll explain this to you. So these are the results in the angles. Now, what you're seeing here are the marginal means, the differences between 0 and 12 weeks for each of the 4 groups: control, strengthening, posture education, and both. And this is after a linear regression analysis controlling for age and gender. And you'll see there were no significant differences, even though I've put red up there. They're the most different, but there are no significant differences between any of the groups and control. And all of those numbers are pretty underwhelming, like everyone else's. But I want to draw your attention to this. In the strengthening group, when we measured with the inclinometer, so we included those top 3 levels, approximately, we got much more impressive changes than we did when we just measured, if you look up the top there, with the goniometer, which is just measuring that apical section, that middle section thoracic spine. Indicating that maybe it's this upper section, when people are measuring between T1 and T12, it's maybe they're measuring most change at the upper section and not this apical section, which is the bit we're trying to change. Physical function, only the strengthening group improved in 2 of the tests, and in only the strengthening group significantly increased strength compared to control. If we look at the effect of this strength increase, however, so that's great, they've got stronger, but in fact, although there was a trend, this did not translate into a decrease in kyphotic angle. But the effect of age is interesting. I'll orientate you to this graph. We've got down here the angular change, and the more negative you get, the more change you've made, so the better you are. And across the bottom here, we've got age groups. And if you look, as we get older, we change less. I guess that's fair enough, but this is interesting. At about 70 years of age, we really don't have any potential to change at all. So to conclude this paper, what we found was that as people age, altering the shape of that apical segment of the thoracic spine becomes very difficult, becomes much more difficult. Strengthening may alter the alignment of the upper thoracic spine, but posture education appears to achieve very little, or achieve less anyway. And this is what I'm saying here about the upper thoracic spine. We wonder whether it's this bit that really made it changed in the other studies. Future studies, I think, should separate these 3 regions, because that upper thoracic spine is anatomically quite different. Even though you've got the rib attachments, which is what defines it as the thoracic spine, anatomically it's quite different, and in many ways more like the cervical spine than the middle section. The strengthening group was stronger, but that didn't translate into a decrease in kyphosis, although there was a trend. Further, it would be really good to have a look at just stretching modalities and see whether that makes any difference, and whether we can actually push the effect out more in terms of our age groups. It would be very interesting to compare stretching with strengthening. Thank you.
Thank you. Any questions from the floor in relation to this paper? No, that's not a hand up there. Anybody over this side? Yes?
Hello, could you explain what exercises you were given?
Oh, sure. Yes, I glossed over that. What we did was I'll see whether I can get it for you back here. I did have a picture. We sent them to the gym, and we put them on a back exerciser, which we'd modified. Here he is. And what we did was we put a block on the back pad here, and we dropped the seat right down so that we were actually getting them to extend and retract their scapulae. And in fact, in the next paper, as I said, they're out of order, I'm going to explain to you why we did that exercise and we didn't do it in prone.
Question from the young lady here.
Diana, thank you for a very nice paper. Can you elaborate on why the group that got both postural education and strength didn't change as much as the strength group? Yes,
thank you, Angie. That's a good question. I'm not exactly sure why that is, although I measured more than I presented to you today. And in their subjective, when I looked at their subjective take on the program that I gave them, a lot of them got a bit tired of doing the lot, to be honest, and I think that perhaps they didn't do as much as a group that just had one or the other. So having a home program and having to go to the gym 3 times a week was a bit much, and perhaps they didn't apply themselves as much as they would have if they've just been in one or the other.
We're up the back here with Robert.
G'day, just following on from those exercises that you said, is it only the one exercise you gave them, and you said you might go into it in the next paper? Is there a reason why you didn't give them a series of strengthening exercises?
Yeah, thank you for that. Yes, I did just give them one exercise, and the reason that I did that was I really wanted to strip down the modalities right down to the basics, and I wanted an exercise which recruited the thoracic erector spinae. I was really wanting just thoracic extension exercises, and that's all, and to see whether that made a difference. So I guess I was being a bit of a purist, and I know that doesn't necessarily apply to the clinic, but by the same token, what I was trying to do was find out where we should be putting our efforts. You know, when we do a multimodal interventions, it's very hard to work out which one it is that's working. So I wanted to use that precious research time that I had doing my PhD to really strip it down.
We have another question up the back there.
I'm Bronwyn, yes. Diana, thank you very much. In the previous paper you talked about needing to do 200 repetitions of a frequency of 0.1 hertz for nutrition between the disc and the vertebral body. Is that exercise a suitable exercise to help with the nutrition? Based on what you said previously?
Yeah, thank you for that. Yeah, no, quite right. That is a strengthening exercise, and in many ways, perhaps it would that exercise may well decrease the frequency of movement by stabilising the trunk. So there we are in a dilemma. But I suppose if you can stabilise the trunk more and I was trying to get people into a better position, i.e. more upright, from which they can move. But having gone through this process, I actually think being in a stable, static position, extended or not, is much less valuable than being able to move out of a position easily and often.
One final question from Tracy.
Thank you for that paper, Diane. I'm just... we're living a lot longer, up to the age of, say, 90 for women. So we've still got another 20 years beyond 70. Yes. I'm just wondering, and presumably we continue to kyphose after the age of 70. I'm just wondering, just some comments, I guess, about how to address the prevention of further deterioration. We may not get improvement, but we may be able to slow down that degeneration.
Just thank you for that, and absolutely, that's where I was coming from. I don't think it should be inevitable, and I think we can, as physiotherapists, address this this decline as people age. It's what to address them best with, and I don't think I've answered that question to my satisfaction anyway. Certainly, the strengthening group seemed to improve things from the point of view of physical ability and strength, and perhaps that would then translate into a reduction in the decline. But I don't know. I'd really like to look at the selective effect of stretching as well in this group. But certainly, more active people are less kyphosed. We know that from the other literature.